Do I need surgery? This is an important issue because it turns out at this present time we have little in the way of other treatment modalities beyond those things that changing your activity, changing the stress levels, physiotherapy, etc., and modifying your weight can do to the osteoarthritis. In other words, it's an incurable problem by other means. Surgery doesn't cure either, but surgery can modify things in sometimes a very dramatic way. Just as we spoke about before, optimal timing for surgery is important. Doing a joint replacement, if that's what's indicated at the right time, has the best long-term outcome. And there's very good evidence that joint replacement surgery is very effective in limiting the pain, improving function, keeping people independent. But we know that doing the surgery too early risks long-term complications. These aren't necessarily that the joint becomes loose, but it doesn't work as well over long periods of time, especially if you're younger and if you're very, very active. Unfortunately, that joint is exposed to the wear factors and those features as well. In just the same context, doing the surgery too late doesn't get the biggest bang for the buck in simple terms. Because if you've got a joint that is really severely damaged and you keep on delaying surgery, you wind up not getting the optimal outcome of return to good function, good capacity to walk, reduced pain, and good stability, which any well-done knee replacement done at the right time can provide. So appropriate surgery at the right time is very important. But when we're on this particular topic, let's understand how do we know when it is appropriate. That's where the OASIS evaluation can, we believe, help a lot. The OASIS knee evaluation is designed to define the nature of what's going on, tell us the extent of the damage, and then allow the following of those changes over time. But your knee arthritis on an X-ray isn't the only reason to do the surgery. It's very important. In fact, it's probably, from an investigative point of view, the most important factor to help the doctor to know that you need something being done. But we see many patients who have a badly damaged knee, and yet they function surprisingly well. Should they have surgery? Not necessarily. If they're functioning very well, we may not have that much more to offer with a joint replacement. So how you're doing, what your pain level is, what your limitations are, is very important. So the link between the radiographic changes and the health status, which we can identify using a questionnaire, is very useful in helping to optimize timing for surgery and the nature of what should be done. What are the surgical options? We can roughly consider them as three, and I'm going to go over each one of these but briefly. Arthroscopy, some people think of that as keyhole surgery. Osteotomy, which is a change of the overall shape or alignment of the limb, and then arthroplasty, where you replace part or all of the joint with artificial parts. A complete knee replacement is when all three compartments of the knee, the inner, the outer, as well as the kneecap joint, are replaced with metal and plastic parts. A partial replacement is when just one compartment of the knee, which nowadays can be the kneecap joint compartment, as well as either the inner compartment, the medial compartment, or the outer compartment, can be replaced with metal and plastic bearings that provide for reconstitution of that damaged area and can restore function. Arthroscopic surgery is seldom indicated. It has been used very widely in the past, but the scientific studies and outcome studies of patients with osteoarthritis that have been treated with arthroscopic surgery to wash out the joint and debridement to clean up the joint have not shown that it is any more effective than physiotherapy. In fact, if you take away even damaged cartilage structures, you can aggravate the problem and make it worse. So sometimes arthroscopic surgery can be a progressive change issue, not a saving kind of an issue. But arthroscopic surgery does have a role. And when there is a loose body in the knee, like a joint mouse, or when there is a change in the surface of the joint where a part of the cartilage is actually blocking motion, arthroscopy can be very useful in taking that piece out and helping to solve the problem. Usually your doctor will want more information than just a plain X-ray to define if you have that kind of a problem of an obstructing cartilage. And in this instance, more than a plain X-ray may be needed, and an MRI might be useful. Usually you can see a loose body on X-ray. So the situation of a patient who has locking and giving way, in other words, sort of mechanical symptoms of something getting in the way of how the joint is working, may be an indication that you're a good candidate for this kind of surgical treatment. What about osteotomy or realignment? From the information that's available to us, osteotomy can play a very, very important role in the management of OA. And many times realigning the joint in a good way to take away the abnormal bowing or the abnormal knock-knee alignment change can allow the other compartment of the knee to load and keep the patient going for years and years, sometimes without any further intervention. So patients that have damage that are younger, patients that are more active, and patients that are heavier but have demanding activities are all potentially good candidates for osteotomy surgery. The radiographic information needs to confirm that there is focal damage associated with a malalignment or deformity. In this particular picture, we're looking at two images of the knee, on your left before surgery and on your right after surgery. Before surgery, the picture on your left shows you a knee where the damage is quite severe in the inner compartment, but also shows you a significant amount of bowing. And after the surgery, you can see that there is actually a little bit of knock-knee alignment, and that joint surface on the inner side looks better. After osteotomy and the limb is corrected, loading of the knee becomes much more general. In other words, it's not focused to that single area where the damage is. Patients walk better with more stability, improved function, less pain. The arthritis hasn't gone away, but you've modified the forces in a major way and improved function. And this may be all that that patient may need for the rest of their life. Joint replacement surgery. We now can do a complete knee replacement, or we can do a partial knee replacement. The pictures here depict a complete knee replacement for a patient with a bad problem. The x-rays on the left show severe bowing, and on the inner side of both knees there's no more joint space. In fact, there's collapse and damage of the bearing surface of the shin bone. The picture in the middle illustrates the severe deformity of this particular individual. And the picture on the right side shows the case after surgery. And you can see how nice and realigned and straight the knees are. Joint replacement surgery can do a huge amount for patients that have got severe damage in the knee. But if we go back to that earlier discussion, optimal timing is very important. Not doing the surgery too early means that this rather radical form of surgery has much less risk of going wrong. But leaving it too late may not get the optimal result for the treatment. So good timing for the surgery is very important.